Hey, everybody. Welcome back to the Vitality Code podcast. I'm one of your co-hosts, Dr. Jason Farrah, along my highly esteemed, well-bearded,
better looking,
more clever.
I got my lunchtime laser treatment last weekend. Can you tell?
Dr. Jeffrey Farrah with his brand new, man, that's nice.
Look at the sheen on that head.
I know, man. Really brings out the underlying.
Easy.
Yeah, let's
not
not go too deep into that, right? Beautiful.
This is from the lack of sleep last night, but
Love it, man. The beard's getting frothy again. I like that
looking
too.
good.
You got some beard oil today or no?
I did. Yep. I went with Grave Before Shave. That's my brand of choice. Shout out to Grave Before Shave.
Grave Before Shave. That's a little. It sounds more. Explain that. It was grave.
That's
like
the brand.
Dying grave. Like
I'm gonna die before I shave this.
Oh, great.
Come on.
That's awesome.
This is a lifestyle. I've committed to it.
I told you were more clever than me. That's fantastic. Grave Before Shave.
They have one that has
baby.
like a citrus flavor. It's the best. Yeah.
Flavor. So you've tasted it. Or scent.
Scent. It's right there. That scroll down a little, Nick. It's that one in the middle.
Excuse me.
It's by far. This is what I tell everybody to look at that guy. That's a good looking beard coming.
Yeah, it is. Man, where have you ever had a go back to that? Producer Nick, let's see that.
What's on that one?
Whoa.
I don't like those. Those
so you're
stringy.
You're not into the bib, right?
It's
the bib.
just stringy and I want a nice
that's
Viking beard. Like that guy. That guy's gonna do it. That's good.
I think you need to grow out the mustache on top.
I thought about that. But it gets in my lip. It gets in my lip, and
even way out there laterally like that.
Oh. I haven't done that level of grooming. Maybe that's where I need to go.
Yeah, because we need to change it up a little bit. Like you've done the long Viking beard. Let's add a little style to it.
If we can get Grave Before Shave to sponsor by sending me some free product, I'll do whatever they want.
Producer Nick, can we do that? We will. Let's do this. Let's reach out to Grave Before Shave. Tell them that we're going to track this on our social media channels. And I
use them. They're great. I tell everybody to use them.
Producer Nick, do we need like a weekly check-in with Jeff on IG or something? What would they go for?
So
okay, and I mean
a weekly post.
I mean, we don't need a lot. Maybe I don't know. What do you need, Jeff? $100 worth of products, $200 worth of products.
More than enough. I'm a simple man.
Yeah, we'll do it, and we'll promote them. Grave Before Shave.
Yeah, they do.
Now let's look at this. Do they have anything that will help you? Anything that will help you grow a beard?
Man, I don't know. I've never had that problem, so I've never looked into that.
Bastard. Producer Nick, tell them.
I keep one bottle, or I use the balm. I have one in my shower. I have one on my nightstand, one in my bathroom, and then one in my office, just in case. Tell them that,
much to the chagrin of my family, I too will join this repartee, and I will. I don't even know if that word applies. I don't even know what that word means, but it sounded good in the moment.
It sounded good.
I will try once more to grow a beard if they will sponsor us.
Well, it's like when we were growing up, Jason. I used to tell Mom, like, when she would get mad at you for things.
Oh gosh, what is this?
He can't be perfect, Mom. Like, it just wouldn't be fair if you had the beard too. You know, I'd be like, give me a freaking bone here. I'm bald. I was losing my hair in my 20s, and you're giving me shit for my beard. Like, you had the luscious locks and the nice curly hair.
I did. But yeah, past tense had some great hair.
You had good years. You had good years, man.
I had good years. Yeah.
You're married now. It doesn't matter.
Exactly. Who cares? But you had the athleticism. You had the beard. You had the angular face.
I had the big. Do you remember I had those big chops in high school?
Dude, you had some sweet chops.
Because you weren't allowed to have beard, but you were allowed to have sideburns. So I was like, oh,
that's the way you revolted. You're like, I'm going to do whatever. I'm going to push the envelope to the. Okay.
They probably looked ridiculous.
They looked pretty good.
All right.
I liked it. I was peanut butter and jealous, man. Yeah. See, now look, let me ask you a question. Look, I got this big gap between the lip and the edge of the beard right here. Does that preclude me from even trying to grow a beard?
Yep. We need an expert in the room, and maybe that's which beard you decide to grow, which style of beard.
Ooh, yeah.
I had a goatee for the longest time. I thought about going back to that.
The goatee, you did rock a sweet goatee.
Oh, hey,
Whoa, hey, sideburns.
General Ambrose
Bruce Burnside. That's where they came from.
That's my new name.
Yeah, you did have some nice, beautiful
General
sideburns.
Ambrose.
Now look at that hairstyle. I'm thinking I think I'm shaving my head if my head. That's not only is it cone shaped, but look at that, the full frontal bald assault
I bet
there.
you wild-eyed and half hopped up on
I
some
know.
amphetamine-based PCP or something.
I know, yeah. Some homemade brew, yeah, some homemade PCP, whatever they could grow out there in the cotton fields.
Yes.
Good God. I put out my gun. Okay, you got me. I'm not messing around with those sideburns or that bald head.
All
If
right.
you have the guts to go out in public looking like that, what a badass you must be. That right there. Damn
Yeah.
straight you're going to be a general. Look at me, boys.
He was
It
destined.
takes guts to go out there looking like this. Look at this. You going to mess with? No, you ain't going to mess with that. Look, man, forget about it. Hey, so I heard you had some questions about the GLPs and the algorithms and the side effects and
It's
patients.
just growing more and more in my practice. I did not realize that, I never intended to set out to do this, but I'm doing more and more and more. And so I'm having to dive in there and having to deal with some patient nuance and having to really fine tune my dosing and my prescription and my treatment with patients with the GLPs, i.e. the semaglutides and the tirzepatides.
Give me a 3-minute editorial on why it's taking off and what that says about the state of health in the country.
I don't know that I could do that.
And your best philosopher prose.
I think I have seen significant pressures that I was not aware of, and significant. I had one patient tell me that it reduced his food chatter significantly. He always had this in the back of his mind.
I call it food noise. Yeah,
and I was like, I never knew that. I it's not something that is true for me. So I just and I said that to another patient. He's like, yeah, 100%. That rings true to me. And I was like, wow, that would be difficult. And so I think there's a lot of societal issues. I think there's pressures to look a certain way. Your weight impacts your health outside of the aesthetics significantly. I'm seeing reductions in alcohol consumption. I'm seeing a strong halo effect. I'm seeing people's moods change significantly as they lose weight. The way they view themselves now changes the way they have outlook on life. So there's a lot of things that I just didn't foresee happening. Now there are some less negatives than I ever imagined, but there are some specific things that I wanted to see how you're handling in your clinic. So the first one was I got hit with this yesterday was constipation, and she's on the tirzepatide. And so I wanted to see.
Let me tell you about that. So when somebody comes in, I think these things are best approached as a lifestyle modification. I don't think fat shaming has a role in approaching this, and obviously we don't want to do that. And I used to think these were cheating. These are not cheating. These are acknowledging the impact of the scourge of diabesity, and that's a spectrum. So the way that glucose homeostasis disruption and obesity go hand in hand, the effect of insulin resistance on muscle, liver, and pancreas, the triumphant, now the ominous octet, there's 8 of them now, and saying, okay, what's happening is that you're getting a resistance and or a deficiency in the incretin hormone system, and you need to rectify that by providing that back to the system until such time as you can generate homeostasis on your own. So that's going to be a lifestyle change in addition to using the medications, and we want to keep you moving forward after you're done using these medications. One of those lifestyle modifications is the health of your colon. As a general and trauma surgeon, I've taken out a ton of colons for diverticular disease, let's say, okay? And so my viewpoint is a little different. It is insane the amount of diverticular disease there is. Not all of it is surgical, okay? But it oftentimes, right. I mean, well, some of it's a management issue.
No, I'm saying I didn't realize it was so prevalent.
Oh my gosh, yes. Incredible. There's geographic.
So we don't want people to get constipation then, because it could be more severe than just constipation, you're saying?
Absolutely. Now, I'm a little bit selection bias, right? So the people that I would see as a surgeon are selected because of my specialty, and so I'm seeing that, and so you start to think everybody's got it. But if you look at the epidemiologic studies, it's a problem. Okay, so you need 40 grams of fiber a day. The average American. Do you
start that before they start any?
There you go.
Start before.
So I tell them, look, you've got to train your colon. You need to be doing these things anyway, and you'll have less chance of osteoarthritis, obesity, cardiovascular disease, hypertension, and everything just from increasing fiber in your diet anyway. Okay. And hydration. So
yeah, I noticed that sometimes with the food content drops, so does the consumption of water drops along with it.
Exactly. So the thirst mechanism in the hypothalamus and the hunger mechanism in the hypothalamus is closely related. As people age, it goes down anyway. Anyways, but so as you reduce the hunger stimulus, you may reduce the thirst stimulus, and hypovolemia is listed as a possible side effect on the drug monograph. Why? Not because it does something to the kidneys or blood volume in and of itself per se. It's the intake of water. So we're going to train your colon. Okay. We're going to acknowledge that constipation is probably one of the biggest side effects. It depends on people's clinical experience. My experience is that the tirzepatide is more effective, but more typically causing constipation than is the semaglutide. Although
I'm seeing that
argue
too.
That yes.
Really? I don't see on Ozempic. I don't want. Or sorry, semaglutide. I don't know if I see it 0, but it's really limited.
So one of the reasons is remember tirzepatide has GIP, gastric inhibitory peptide, which was the old name, and now it's a much longer name, but it stimulates the ileal brake in the distal ileum, and so not just gastroparesis or slowing the gastric, not in the duodenum, the first portion of the small bowel, but way down into the distal small bowel, and promotes the ileal brake, it's called. And so I find that it tends to, while it's a much more effective drug, it causes more incidence of constipation that I see clinically, and there's a reason for that, and that is that second receptor it hits, the GIP receptor. Okay, the other incretin hormone.
Okay, so we're gonna increase our lifestyle stuff, our fiber and our water intake right off the bat.
Right, but we're gonna do it and we're gonna do it with the mindset of we're gonna train our colon and front run the constipation, and we're gonna do it very systematically, because you can get into problems and bind yourself up and promote constipation and bloating and pain just from your colon not being used to it. So 1 teaspoon Metamucil, 14 ounces of water. I purposely put a lot of water just to promote hydration every single morning. Don't do it at night. You're going to be up all night peeing. First thing you get up, go in, and I do this. I go in the kitchen. My wife hates it. There's a cup sitting there with a spoon in it. Yeah, damn cup. And so, but I need something to remind me, right? Mix it up. You do that 1 teaspoon, which is a very small amount of fiber, but you do that for 4 weeks. I used to say do it a week and then go up in the next week, and I found that doesn't work. You literally have to train your colon. It takes work, but it's incredibly important to the health of the colon.
So every day, 14 ounces of water, 1 teaspoon of Metamucil
for 4 weeks. The next
prior to starting, or right when you start?
Right when you start.
Right.
Ideally prior to starting, but
you're right.
You encounter them. So
you don't encounter them before they start.
Right. So for 4 weeks, so it's a 3-month period. The next month, let's start in January 1. January, that's what I'm doing all January. February, 2 teaspoons, 14 ounces of water. March, 3 teaspoons, i.e. a tablespoon, and that's where you're going to stop and you're going to maintain. That's going to bulk up the stool, make it easier to pass, and what you need to be doing anyway, okay? Help lower cholesterol, blood pressure, osteoarthritis, weight management, numerous benefits anyway, okay? Avoid the scourge of diverticular disease and its associated maladies, okay? Next, if during utilizing that it becomes a problem, then it's kind of dealer's choice. The things that I avail myself or recommend to patients most is Miralax, Senokot, and Dulcolax. Some people know right off the bat that Miralax is tough for them and causes, I hear not infrequently, bloating. So if that's the case, they either don't want to use it, or we do, instead of a capful in the recommended amount of water, I can't remember exactly how much water it is, 8 or 10 ounces, half a capful. And again, you're kind of training yourself up. If it gets worse, Senokot and Dulcolax, I don't do them one or the other. I do them together. They work in different ways. And I find they work more productively together than do they not, and it's not dangerous. If they don't want to do Miralax, I go right to the Senokot and Dulcolax, and on an as-needed basis. But the backbone of this is lifestyle modification with increased hydration, making sure your electrolytes are okay to enhance intestinal motility. And number 3, the lifestyle is fiber. Then number 3 is symptomatic relief with Dulcolax, Senokot. And then there's a number of anti-constipation medications that you can go in from there, milk, magnesia, et cetera, et cetera. Fourth, and back on number 2, electrolytes specifically, will often, right from the get-go, if they trend towards that. So I ask them right from the beginning, do you trend towards constipation in your natural basal state? If the answer is yes, I start them on a magnesium supplement as well, right from the get-go. So fiber and magnesium, magnesium supplement.
That low-hanging fruit right there.
That's very low-hanging fruit. And
dang, I feel like an idiot right now. I have it in my office.
Everybody has it in office, right?
Yes, I use it for sleep. I use the magnesium threonate for sleep.
Yeah, and everybody's on magnesium anyway right now, and there is a lot of magnesium deficiency, I'll say, especially people that drink alcohol.
Yeah,
and
I'm going to get on that today.
So everybody, training the colon, magnesium, and then, optimizing other electrolytes, and then symptomatic relief after that. That when they do those things, and we start out that way, it's almost virtually not a problem.
So let me ask you this question. If it becomes a problem, because I ran into that specifically in the office, maybe could be accused of not addressing some of these things beforehand now that I'm hearing your protocol, but they have constipation, and we came up with the plan of changing her dose by splitting her doses. Have you seen this, done this? Is there any efficacy?
Let me give you the background of that, and then I'll address it real quickly here. I think my bias is, and this is my personal opinion, and it rings true for a lot of people. Way back when, I did about 3 months of tirzepatide. What I noticed, and a lot of people do this, is that you notice some early success. It takes a while to kick in, right? You have to get that steady state. So for tirzepatide, 22.5 days until you reach steady state. Then you can finally judge if the drug is working or not. But then it works. 1 month, 2 months, and then you see the weight loss. Then you're like, oh, well, if 1's good, 2's better, 3's good, 4's better. Everybody has the same thing. I got to go up. I got to go up. If you look at the studies that were done, the across the board acknowledged issue is that the symptoms seem to be the worst when you jump up on those big jumps, right? It's that stair-step fashion.
Yeah,
4 weeks, jump up, 4 weeks, jump up, right? And those were, I think that's arbitrary, and it's arbitrary to me because I do it because arbitrarily, or the arbitrary nature of it is that it was what the studies use, so I use it, But you tend to get greedy with your weight loss, like we all do, and you want to accelerate it. When a paced, methodical method is better because, number one, it's better adaptively speaking, and then it tends to reduce the side effects. So I tell people, look, you're going to want to jump ahead, and you're going to want to increase every week you come in here because that's the nature. Oh, we did a little before, now why don't we go forward? So let's acknowledge that, and let's tell you what the side effects are if you do that. So keep your eye on the prize. If you're losing weight, and even if it slows, like the percentage weight loss each week slows, but you are losing weight, don't be in a rush to jump up to the next level because you will incur those, okay? Or if you're incurring those and you've been losing weight, don't feel bad to scale back so long as you're continuing to lose weight, even if it's just a pound or two, right? Because you don't want to be miserable. You've talked about this before, right? You don't want to be miserable just to make yourself lose weight because you can't function like that. And, I mean, in a worst case scenario, structural colitis and there's constipation pathology that can lead to perforation or other maladies of the intestines, the colon, etc. So in an extreme case, we don't want that to occur, obviously. So that's one thing. Number two is, instead of a big jump in a stair-step fashion, it's completely viable to take whatever that jump is from week 4 to week 5, week 9 to week 10, whatever, or what I'm saying, and divide it by 4. So it's usually every 4 weeks a jump, right? Take that, if it's a 1 milligram jump, let's say, divide that into 4 and go up by 0.25 each week. And that's completely viable. It may take a little bit longer to reach a steady state, but at least you're increasing and you will eventually reach your new steady state. Meanwhile, you can judge the side effects, and those side effects tend to be dose dependent.
I tell patients we're looking for the lowest effective dose is kind of how I term it to them.
Yes, that's it. That's a very good way to say it because people get really fixated on, I got to increase my dose. I got to drive this. I got to get this weight off me. It's working. Let it do its job. Let it take some time. Remember, each new dose change, you have to go 4.5 half-lives to get a new steady state. So, I mean, that's that's probably the rationale of the stair step, right? New dose, 4.5 half-lives, new dose, 4.5. So I'm not going to so once I get to a new steady state, I'll judge the side effects, I'll judge the effectiveness, no side effects or manageable, tolerance, weight loss, good. Now jump up to the next dose and then wait for the new steady state.
Do you find that also help reduce the effects of like nausea? Because I've seen that to be
100%.
true. as well.
Those are dose dependent. Yeah.
Have you had anybody have any trouble coming off of it when they reach their weight loss
Define
goals?
trouble.
I'm thinking of one patient in particular. Said they were eating fine, drinking fine, met their weight loss goal, felt good, but super lethargic, having some vertigo, and wanted to know if the medication was implicated in that.
Okay, now hold on. Are you saying the medication was causing that, or coming off of it caused it?
Coming off of it. I just wonder if you'd seen that anecdotally in your patients.
I've seen that as a inferred cause, or an implied cause of the medication not coming off of it.
That's what did great while she was on it. It was when she was no longer on it.
There's a lot of things that we don't know about this medication. We know where these GLP receptors are for the most part. Well, first of all, there's three incretin hormones that we know about. GLP-1, 2 we don't know much about and don't use, or to my knowledge there's no medication, and the GIP. And then the receptors, right? There's, like, I had a patient said, I'm noticing some palpitations, and was implying that it was the medication causing these issues. And I said, in my mind, I'm like, I don't even know if there's cardiac muscle receptors for these GLPs. I went and looked it up, and sure enough, there is. And so I was like, well, geez, it's not in the drug monograph. It's not described in the literature anywhere that I could see, and had done pretty comprehensive search. Could it be? Yeah, let's get you off of it. I don't know, but I'm just saying that these receptors are everywhere in the brain, or it should be everywhere in the body, and we just don't know what a lot of them do. So it's possible that could be caused. There was a recent study that came out, for instance, demonstrating that there was neurologically driven inflammation in the body linked to these receptors, and taking the drug decreased that level of inflammation. But that inflammation was from the brain specifically. It was very interesting. In other words, if you hit the other receptors and not the brain, then you still would have the inflammation because the brain was driving it specifically. So it was not just hitting the receptors, it was hitting the receptors that were the GLP receptors in the brain. So I don't think we know everything about these medications. Well, I know we don't know everything about these medications. They're amazing medications for sure, but we don't know everything about them. I've not seen that specific one.
Yeah, I hadn't seen it in any of my other patients. And
the way I do it is I do think there's a risk of rebound hunger, and those types of issues are kind of backtracking because of those issues.
Do you think the rebound hunger is bigger than their initial hunger drive? Or just a return to steady state? I describe to my patients, I have not seen a bigger than baseline, like, elevation. Like, it doesn't crash your metabolism like if you're taking stimulants.
Okay.
It's going to return to what it was potentially.
Right.
If you haven't done the lifestyle things during this to change that, then you're just going to return to your normal.
Right. So I would kind of liken that to alpha inhibitors for blood pressure, right? And so alpha 2 inhibitors, so one of the things is rebound hypertension if you just suddenly stop those, right? So not higher than normal blood pressure, but actually way up, bad problem.
Yeah.
So no, I'm not seeing it where it goes above than what it was prior to starting, but enough to sabotage some of the gains.
Correct.
So the way in which I approach that is you've got to make lifestyle changes with these medications. Do not rely on the medications only.
Which is sometimes why a slower pace works better, because you have more time to implicate lifestyle changes.
Or inculcate. Yeah.
If you're on it for a month and lose a ton of weight, there's no changes that have made in your lifestyle. But if you're on it for 3, 4, 5, 6 months, and you're like, now I understand what I should have been doing. Now I should be going out with the boys every night, or the girls, and drinking wine, or whatever the thing may be. You have
3
time
things
to reset
is,
that.
number 1, don't rely on the medications only. Incorporate lifestyle changes. What's the evidence to do that? One is, and then my third point is that The study patients did that. They
Right.
did 5 days a week, 30 minutes of exercise, ate 500 kcals less than their allotted dietary requirements, had nutrition counselors, dietary counselors, and there was one other thing, a couple of things they did. So there was big lifestyle changes that occurred. Why would you think that you could be any different than a study patient? Okay, that's what we're comparing ourselves to anyway. That's the comparison group, right? In which we should compare our results to. Next is you're making physiologic changes for sure, and those are important, but you've got to sustain those. And part of that is the physiology. We need to resensitize your muscle, liver, and brain to insulin and the incretin hormone system. But we also need to change your supratentorial habits and the way you approach life, and realizing that some of these things were maladaptive and harming you. And oh, by the way, like you're saying, alluding to, time on task produces that 90, 120 days. New habits are formed, more like 120 days. And so adding that down regulation time to the back end, I've met my weight loss goals. Okay, 2 more months, and let's start to cut these drugs in half and get close to where you started, and then come off. Will not only allow for more time on task and adherence to the program, but also avoid the physiologic rebound, quote unquote, that could happen. And yes, it's not as profound as going back over and above where you started, but it is enough to sabotage gains.
Let me ask you one more question before we wrap up on the dosing specifically. Is it reasonable, or have you used in your clinic, say someone, let's just use non-true numbers, like someone's on 1 ml of the medication and they're having problems, splitting it up into 2 half ml shots a week instead of 1 ml a week, similar to like you would do for testosterone?
Wait, what now?
Someone is on a dose of the tirzepatide or the semaglutide, and it is X amount. You take that, instead of doing that once a week, you take half of that and do that twice a week.
You're saying, is that a strategy?
Yes.
You got me. I don't know. I mean,
You
I
guys
guess
don't. You guys
I've
haven't
never
seen
done that.
I had a patient ask me that. He's like, my buddy's doing this. He said he ran into trouble, and his doctor told him to do, instead of doing it 1 big dose per week, same dose total, cut it in half and do half and half.
I don't think that's wrong. You're just going to change the whole pharmacokinetics and the graph. Like if you think of it as a graphical representation and area under the curve, like, you know, a derivative, you're going to change how you move forward and how long you're on the medication potentially. I would favor, instead of that, looking at the dose you want to achieve and breaking that up into a 4-week segment and just going up by 25% each week, but still doing 1 time a week, just because the pharmacokinetics are easier to understand and adapt to in my mind, meaning the half-life of semaglutide is a week. So it's easy when you're doing 1 shot a week. Now, if you do 2, it's not that you can't, but it's just a whole nother set of pharmacokinetics, and it makes the math harder, makes the calculus harder. I don't think
you
this
set
is
yourself up for potential failure just in logistical means.
Right, and I don't know how to. I don't know that math, and I don't know that calculus, and I don't know those pharmacokinetics, and would need to consult with, like, maybe a pharmacologist. Is it wrong?
Yeah.
Not necessarily. It just going to take more work.
Yeah, I thought that was an interesting approach.
Here's the key: is that the study patients were on the medication. Let's look at the 2022 study in the New England Journal of Medicine on tirzepatide for weight loss, and all the studies were very similar. 72 weeks on the medication, right? So 1.5 years. As long as you now, budgetary concerns are an issue, maybe side effects are an issue, but go to the like you said, the lowest effective dose. If you're losing weight each week, and it's a dose that you can tolerate, you know, go up, see where you hit the wall, where the dose is intolerant. You're intolerant to the dose because of the side effects. Come down to the highest dose. Well, I mean, I guess lowest effective dose really is what you want. But I mean,
the highest dose you can tolerate,
right?
Quote unquote.
Guess, yeah, or the lowest effective dose. So, in other words, my point is this: if each week you're losing weight, then just keep going. I mean,
I agree.
and just accept that it may take longer than other.
And some people are exquisitely sensitive. Some are less sensitive. Some are doing all
100%.
this lifestyle before they even gotten here. Some are trying to learn the lifestyle as they go. And so there's very different.
So, and remember, that's true. Lifestyle, your level of deficiency or resistance to the incretin hormone system varies based on how obese you are, how long you've been obese, and there's good genetic studies. Ralph DeFranzo writes about this in terms of your insulin sensitivity and beta cell fatigue, beta cell function. It's absolutely genetically linked. And so there's no reason to think that the incretin hormone system would be any different. In fact, we've got proof that it's not. So everybody's going to respond differently. It just may take you a little longer.
I agree. I appreciate it, Doc. That helps me.
Helps, yeah.
That helps me a lot, actually. The magnesium, I feel almost, we got to make changes and we can't know it all, but I feel silly for not even thinking of that when I have this stupid stuff and I recommend on a daily basis for other things. And it's like, I was like, geez.
This is why you tune into podcasts. This is why you create podcasts. This is why human beings exist, is to help each other. So if everybody knew everything, we would have no need for each other. Thus, we would have no, seriously. And so if you recognize that, surround yourselves with experts and people that are committed to finding the best answer and doing the best work, and just learn from them. You can't have all the answers. You've taught me last episode. You taught me some stuff. Every episode, you're teaching me stuff. So don't feel silly. In fact, you should feel smart, because you're doing this and we're learning together, and we're going to take it to our patients and help them get better.
I agree. And on the bigger picture, you may one day get a beard like me if you start using Grave Before Shave, our newest sponsor here. Yes.
I hope that producer Nick, I hope that one day we can announce that as our newest sponsor.
I think about it doesn't matter if they give us any product; they are a sponsor of the show, because I use their product and my beard drives the show.
That's right, dude. Whether they know it or not,
whether they want it or not,
whether you want it or not, you're sponsoring this damn show. Hopefully, we can live up to the hype. So you know what we're going to start doing? We're just going to start talking about them before every show. We're going to give a shout out to Grave Before Shave.
Yeah.
Hopefully we'll have some remuneration by products, but if not, we love you guys.
I'm okay.
You make a great product.
If you come back next week with this just giant full beard, then we'll know.
I don't know. I might have to put Rogaine on my face or something. All right, guys.
All right, brother.
See you later.
All right, brother.